The metastatic melanoma, similar issues and discussions, and we'll start with the whole BRAF and BRAF mutant wild type story, and I'll turn to you, Caroline, as well to start for this. Similar debates, what do you choose? We don't have randomized data, tell us which way to go. Let's start with efficacy. Efficacy of immunotherapy versus targeted therapy. Is there a difference? And survival rates, 2 years, 3 years, whatever data we have.
Yeah, we know.
Looking at the latest ASCO, which one of the abstracts is yours. So.
Yes, we have some results. We have long-term results. We know the response rate is much higher with BRAF/MEK than with anti-PD-1 monotherapy. And the difference is a little bit smaller with anti-CTLA-4 anti-PD-1, but still 70% of response rates with anti-BRAF, anti-MEK for the first evaluations, usually very early responses. However, as we said before, we know that the curves are getting across each other about 15 months, after 15 months, and we have the PD-1 containing curve that get on top. So if you have the choice at the beginning, if you don't have a patient with a very high tumor burden, you're afraid the patient is not going to be alive in 2-3 months, usually we would initiate with an immunotherapy. But we know that, I think it's important to remind everybody that immunotherapy also has a lot of resistance mechanism that can be upfront or can appear secondarily. And it's important because a lot of patients and the media and everybody talks almost only about immunotherapy, but we also know, and we have published that recently, we have presented at the ASCO, that we also have long-term benefit with anti-BRAF, anti-MEK, first line, with 20% of the patient free of progression at 5 years and 1/3 of the patient alive. So it's less than what we see with immunotherapy, but still it means that some patients really benefit for the long period of time. And I have some patients who have had this therapy without any adverse events for a long time. The truth is that we don't dare to stop. And this is a big difference, because a big revolution that we lived through was that we learned that we could stop the treatment and keep the patient in response and in complete response. And this was a wonderful news that was quite recent in our field, which we cannot obtain with targeted therapy today. We are afraid to stop.
Not yet, yeah.
No.
Can you comment on KEYNOTE-6? You presented the updated results at ASCO. So the survivals are looking for monotherapy, because it's always a choice between mono and combination. And
yes,
KEYNOTE-6 is monotherapy.
so with anti-PD-1, if you look at the patient in first line, you have 43% of patients alive at 5 years.
Yeah.
And the patients who have done the treatment, who went through the 2 years of treatment, we have stopped after 2 years, and the patient who benefited, so they are complete responders, partial responder, or stable disease. I think a lot of the partial responders and the stable disease are hidden complete responders, because sometimes you cannot really make sure that, because you still have something, a scar or something. But these patients, when you stop therapy, most of them remain
in the same condition. Dirk, CheckMate 67 had updated data, mostly at ESMO, and then you presented quality of life analysis at this meeting. Can you comment on the combination? What are we looking at in terms of long-term benefit and quality of life as well?
Yeah, I think what we have seen and learned is what was actually also seen in the KEYNOTE-006, that the monotherapy using a PD-1 antibody has long-lasting tumor control in a substantial fraction of patients, starting actually to stabilize after 2 to 3 years. And we are expecting to see 5-year survival data and PFS data at ESMO in autumn this year. If you look at the tumor control in comparison with the combination, there is even an increase, which is statistically significant for the PFS in favor of the combination, which is not significant if you look at the overall survival. It's around 6 to 7% in favor of the Nivo-Ipi combination, with a overall survival rate at 4 years above 50%. So median overall survival is still not reached at 4 years. So I think This comes to a price, which is a toxicity, what we have discussed several times, with roughly 1/3 of the patients dropping off very early within the first 6 to 10 weeks. The good news, I think, is that a lot of these patients, also it's cumbersome to treat all these toxicities, that a lot of these patients stay free of disease and free of further treatment. I think if you look at the 4-year landmark, you see that a substantial fraction of these patients, roughly more than 100 patients at that point, have not seen any further treatment. And I mean,
it's a treatment-free interval.
Yeah.
Treatment-free interval, and the proportion of patients who never needed any further treatment. And I think that's a quality we have not seen in oncology. So I mean, I think the quality of life, which was going with it, and this is a very ambitious project as part of Checkmate 67. Quality of life was not only measured during the treatment period, but also now up to 4 years. And I think there is a clear indication that this suffering through the toxicity is worthwhile for the patients.
But I think it's very important what you said, because very often we have patients refer to us or colleagues asking us, we have this huge toxicity, do you think we can re-challenge? And we always say, wait, look at the patient, evaluate your patient with a CT scan before even considering re-challenging. And that's also very new. And very often we don't need to go back to the treatment. So that's great.
And Lex, you're going to make a comment, but I want to ask you one more thing as you think about it. There was an ASCO abstract about depth of response in terms of that correlating with outcome or benefit. Do you think that's important? You're a surgeon, obviously you get a complete response every time you operate. So what do you think about depth of response, and in terms of the toxicity as well, if you could comment, please?
Well, there is a fairly good correlation with PET scans, but PET scans still are still hot, showing some inflammatory activity, and so they're actually underestimating the pathologic complete response rates. So although there is some linearity, there is still quite a distance between the PET readout and what is the pathologic readout. So we underestimate the responses. There are many more complete responders actually than we think, and we only find out because of the survival curves. The point I wanted to make is that in general, in discussions, the 3-year, the 4-year, the 5-year survival rates between BRAF/MEK combos and between immunotherapy are compared, whereas you are comparing a BRAF mutant population to the overall population in the immunotherapy populations, which is incorrect. So you must realize that the BRAF mutant patient population has much better survival curves than the BRAF wild type patients. And so the real difference between at 3 years is that for BRAF/MEK combo, it's 45% overall survival at 3 years. But for the Nivo low-dose IPI or Pembro low-dose IPI combo, it is for the monotherapy with anti-PD-1 already 59%. Sorry, that's already 14% higher. And it's 68% for the combo. That is 25% higher than the BRAF/MEK combo for the same patient population. So we should stop comparing overall populations with BRAF mutant populations. When we make comparison, we make the comparison between the 2 BRAF mutant patient populations. And this is why we sort of brush over the difference. No, the difference is huge. It is at 3 years a whopping 25% overall survival difference. And already monotherapy with anti-PD-1 is distinctly better than BRAF/MEK combo. I'm sorry. So we must stop making the wrong comparisons and only make the right comparisons.